Well, I'd like to thank everybody for joining us today for this conference. We're going to talk about TCT 2020, the structural heart clinical takeaways. I'm going to be one of your panelists along with my good friend and fellow surgeon Kendra Grubb and my good friend Mohammed Abdel Wahab. And we're going to start off talking about comparative TAVR versus TAVR studies. So I'm going to talk today a little bit about scope 2. Remember, scope 1 was the accurate neo, or the previous generation of that valve, versus the S3 valve. Scope 2 is the accurate neo versus the Evolute and Evolute Pro family of valves in a one-to-one comparison. And this was presented and published simultaneously at the same time. And if you look at these two valves, we of course all know the core valve Evolute family. It's a nitinol-based valve with porcine pericardial leaflets. It's self-expanding, it's recapturable, it has annular fixation. It does not self-align. And in this particular trial, we only used 26 and 29 because it had to be something that we could randomize against the sizes of accurate that were available. And although it covered an annular diameter of 18 to 26, we really could only do annuluses from 21 to 27 because that's what fit the accurate neo. The sheath size, of course, for the Evolute is 14 and 16. We move over to the accurate neo. It's a nitinol valve. It's porcine pericardium. It's self-expanding and superannular. It is not recapturable. It does have annular fixation, and it does align itself when the distal bars come out. It deploys from top down. And it comes in three sizes, 23, 25, and 27, which they call small, medium, and large, covering annular sizes from 21 to 27, and 18 and 19 French delivery systems. And the study design was to look at patients with severe symptomatic aortic stenosis that were over 75 and considered high risk. And they looked at 796 patients randomized one-to-one between the accurate neo and the core valve Evolute. And the primary endpoint for a non-inferiority test was all-cause mortality or stroke at 1 year. And the key secondary endpoint, which was powered for superiority, was new pacemaker implantation at 30 days. So if you look at the baseline characteristics, these are very similar. The mean age is about 83 years of age. It's about 2/3 female. These tend to be smaller annuluses. There's no large neo valve. And they tend to have fairly consistent symptoms and risk assessment between the two, about 4.5 for the STS. And there was, for the non-inferiority, there was an absolute margin of 6%. And for the superiority, there's an absolute margin for 7%. And for the non-inferiority primary endpoint, they were going to look at both the intent to treat and the per protocol. And by the study protocol, if both of them did not meet non-inferiority would not be claimed. And if you look at this 1 year intent to treat, you can see that they just barely missed non-inferiority, whereas per protocol, they made non-inferiority. So because both of them did not make it, the trial was considered as did not reach its non-inferiority endpoint. If you look at the superiority for pacemakers, 10.5 for accurate neo versus 18 for core valve Evolute. So it did reach superiority. I think most of us that have a lot of experience with Evolute see lower pacemaker rates than this. My pacemaker rate for the last several years has been in the single digits for Evolute. Now, if you look at the secondary endpoints at 1 year, you look at all-cause death, there's no real difference there. The big surprise was there were more cardiac deaths at 1 year in the accurate neo than in the core valve. Now, you have to go back to 30 days and realize that at 30 days, there were 3 cardiac deaths in core valve and there were 11 in accurate neo. So it was almost 4 times as many at 30 days. And if you look at the cause of those deaths in accurate neo, 3 of them died before the procedure even started. 1 was a coronary occlusion, 1 was an annular rupture, and 1 was ventricular perforation. So that really kind of carried through all the way to now. No real difference in strokes, no real difference in bleeding, myocardial infarction. As we noted, pacemakers were superior for the accurate neo. It does stabilize early and does not go low into the ventricle. Rehospitalization was no difference. No real difference in left bundle branch and no real difference in tachyarrhythmias. So if we look at 30 days, if we look at the core lab assessment for aortic regurgitation, you can see that there is more moderate to severe aortic regurgitation in accurate neo than there was in core valve. When you get to 1 year, there's still a difference there. I will point out that this is the previous generation, the accurate neo 2, which is the current generation, which would be their version of the Evolute Pro, has added a more robust skirt for paravalvular sealing. That trial is going on in the US right now, so for full disclosure, I'm actually the PI in that trial. So that's really the basis for scope 2. It's missed its non-inferiority because it only made it in 1 out of 2. And so now we're going to move on to the Solve TAVR, which is a 2x2 design between Evolute and S3. and general and local anesthesia. So Mohammed will now take us into Solve TAVR 2x2 factorial design. Mohammed, please.
Yeah, Michael. So this was a trial that was performed in Germany a few years ago. It's a 2x2 factorial design trial that included almost 450 patients with severe AS undergoing TAVR. And there were actually two randomization arms. The one was the valve strategy arm. So patients were randomized 1-to-1 between Evolut R and SAPIEN 3. And the other arm was the anesthesia arm. Patients were randomized 1-to-1 between local anesthesia with conscious sedation versus general anesthesia. The primary endpoint of the trial for the valve strategy and the anesthesia strategy were separately published last year. And the data presented at TCT Connect were concerning the 1-year follow-up. So these are, this is a summary of the 12-month echocardiographic data, and you can see here what we know also from previous iterations from the supraannular self-expanding versus the intraannular balloon expandable devices, that you have better hemodynamics with the supraannular devices, so less gradients and slightly higher orifice areas at 1 year. And when it comes to the 12-month clinical outcomes, so the composite primary endpoint, which was really a rather big endpoint, including mortality, stroke, moderate, severe paravalvular leaks, and pacemaker implantation. The trial was powered for equivalence for the composite endpoint at 30 days, and at 1 year, the same composite endpoint was still equivalent between both device types, so no significant differences. Also no differences in mortality, in all-cause and cardiovascular mortality. As for stroke, and this was already seen at 30 days and it remained so at 1 year, there were significantly more strokes in the balloon expandable group. Moderate to severe paravalvular leaks were not significantly different, and also surprisingly, permanent pacemaker implantation rates were quite high in both groups and they were not significantly different. This is the Kaplan-Meier, or the cumulative incidence curve for the probability of death and probability of stroke, and you can see here the findings we pointed out to. So no differences in total mortality, but a significantly higher stroke rate with the balloon expandable valve at 1 year, which is something we may wish to discuss. I can also shortly go on or summarize the design of an important trial that has been announced at TCT Connect, which is a trial that is going to be sponsored by Medtronic. It's a trial that will include more than 750 patients with a small aortic valve annulus. It's called the SMART trial. And this trial will randomize patients with a small aortic annulus or a small bioprosthetic surgical valve between the Evolut Pro Plus platform and the SAPIEN 3 or SAPIEN 3 Ultra platform. This trial will be randomized 1-to-1, stratified into two cohorts, the native cohort and the surgical aortic valve cohort, and randomization will also be further stratified by gender. The native cohort will have two co-primary endpoints at 12 months. The first one will be a combined clinical endpoint of mortality, disabling stroke, or rehospitalization. And the second co-primary endpoint will be bioprosthetic valve dysfunction. The primary endpoint for the TAV and SAF cohort will be bioprosthetic valve dysfunction at 12 months. And there's a planned 5-year follow-up for all patients. I think this is honestly a very smart trial, not only the name, but also the design. And it will give us important insights into treating patients with small anatomy. And with that, I'll go back to you, Mike, for if you want.
So let me ask Kendra Grubb to comment on this, Kendra. So this is going to be an interesting trial, the SMART trial. It's obviously going to be very heavily laced with women because women are going to have smaller annulus than men. And, you know, although we can index to body size. Once we get to an EOA, the EOA really controls flow. And do you think this is going to show much of a difference as far as exercise tolerance and quality of life?
I do. I think that we already believe that in the smaller valve sizes that there is a difference, and this will just go on to prove it. I will say that I was kind of impressed by some of the work, and I know we're going to talk about some of the other abstracts, but we're in a different era now. We're no longer talking about can we do TAVR and have good results. We are now questioning what we're doing and is this the right thing for the patient? And whether you're talking about a ballooned expandable versus self-expanding versus a totally different design of a valve, I'm encouraged by where we are. The surgical precedent set the bar high. And in TAVR, we really have to be very, very critical of the work that we're doing. And what you're seeing is that people are interested in how to do TAVR safer. And I think the SMART trial may not be safety, but it's long-term durability. And I think that's really the ultimate goal, the lifetime management of these patients. And can we give a very good result with the first valve, because we're going to have to build on that platform.
So let me go back to Mohammed for a minute. So Mohammed, I agree with Kendra that we know we can do TAVR now, and we can do TAVR really pretty well now, all of us in big centers. But we're really looking for ways to really make it better for our patients. And one of the things is we'd like to decrease their time in the hospital and even shorten further the recovery time. When you go back to your 2x2 trial, although we didn't see any real differences between general anesthesia and sedation, do you think going forward we're going to see that if we did enough patients? When you really look at not just the mortality, which is pretty blunt, but really patient preference and how quickly they get out of a hospital?
Yeah, I mean, it's quite difficult to do a randomized trial comparing these different anesthesia approaches, because also designing such a trial would mean that you have to choose a certain endpoint that shows you the difference. And I don't think the difference will be in mortality or in hard clinical endpoints. But as you mentioned, it relates to patient comfort. It relates to the speed of recovery, to the speed of discharge. And I would like to remind you that the majority of patients in the control arm in this trial, they actually received more or less some sort of conscious sedation. So it was not a trial comparing local versus general anesthesia as we define local anesthesia currently, but it's more or less a controlled conscious sedation versus general anesthesia. And I think if we want to move forward with this, and if we want to design a further trial, we should actually compare doing local anesthesia without any form of sedation, which is something that we are currently, I think, in the routine TAVI practice doing more and more, and compare this with conscious sedation.
So let's talk a little bit about head-to-head trials. And Mohammed, if I'm remembering correctly, you ran one of the initial really good trials, the CHOICE trial. And it was interesting because it seemed like the outcomes changed from year 1 to year 5. What do you think about head-to-head trials, and where do you think the pitfalls are?
Yeah, thank you, Michael. I think this is a very good question. So I think we learned a lot from this initial experience with randomized head-to-head trials. As we mentioned now, also the endpoints we are looking at now are very much different than those we were considering in the early days of TAVR, where we were very much focusing on the success of the procedure. And now we're moving a little bit forward, as Kendra has mentioned, into lifetime management aspect, durability aspects, and so on. And these will be extremely important if we're going to design head-to-head randomized trials in the future. So it's a little bit beyond the procedural success and moving forward and looking at long-term outcomes. This is one thing. The other thing, and I think this is also one of the things we learned from the early trials, that the field is very competitive now. And there are some devices that are much more ahead of others. So, and if you are going to compare the newcomers now to the established devices, as we've seen, for example, in the SCOPE trials, it will be one way or another a little bit unfair to the newcomers, because they are at a much earlier stage of development. Yeah. And the moment these results are out, newer iterations are already in further trials, as you mentioned, the American trial that is being headed by yourself. So these two aspects, how to choose the correct endpoints and how to choose the correct devices to compare, I think these are two important points that we have learned from the previous one.
So before we go on to abstracts of interest, let me ask Kendra Grubb one question. Kendra has been one of the thought leaders in cardiac surgery and structural heart disease in the US. So Kendra, bicuspid valves, are we going to have a head-to-head, either valve versus valve or valve versus surgery, do you think, in the next couple of years?
Well, you heard me on a podium once say that I didn't think we were ever going to have head-to-head trials, although they were needed. And so I stood corrected right now, and I do think it's needed. I think that we actually do need to study that in more depth. The bicuspid registries that we have and the bicuspid data that we have now is small in scale. We have some indication of how TAVR valves perform based on the low risk groups, but I think you do need a head-to-head. I think it's really important.
Let's move on to TCT abstracts of interest. So there's several abstracts that are out looking at pacemaker rates. And you see them listed right here. And these are pacemaker rates using double cusp overlap. Now, we've been using this for a long time. Hemel taught us this several years ago. In the Evolut low-risk trial, Hemel was my #1 implanter, and his pacemaker rate was 1.9%. As I said, mine has been in the single digits, and you can see that with appropriate placement, the pacemaker rates that we can see, both from the US and from Hemel South American experience, which you see in the bottom listed in red, can be less than 10%. Mohammed and Kendra, any comments about how you're doing your self-expanding valves now?
Well, we adapted to this technique in January of 2019. And I think that at Emory, we see very similar results. Our pacemaker rates are consistently in the single digits. We continue to refine our technique, go to a stiffer wire to make the procedure a little bit easier, a little bit more reproducible. And I am a believer. I'm a little bit biased as one of the PIs of Optimize
Yes.
Pro, but we adapted to it and are getting really good results.
Yeah, so we're really looking forward to Optimize Pro, Kendra, that you're running, because I think that, if we standardize this, as I said, we know we can do this. Now we're trying to take the procedure and standardize it for the best possible results. Mohammed, what are you doing with your self-expanding valves?
Yeah, I mean, we are also like adapting ourselves, of course, to the new implantation techniques. But what I really like about these innovations and these changes in practice is that you get options. So you don't only have one way to implant the device, but you have several ways, and you can adapt your implantation technique to the patient anatomy and to the patient needs, which is something that we were missing actually. So we were implanting all valves in a similar way. Now we're looking at things like in which view, which technique, how to align. I think we will see this in a few slides. And then you can really adapt yourself to the patient needs, which is something we are doing, for example, in coronary interventions, but was missing a little bit in valvular interventions. We don't only have one stenting technique to a coronary bifurcation. We adapt ourselves to the anatomy and to the patient needs. And I think this is the correct development of the technology, that you have options.
I agree. Again, another example of, we know we can do this pretty well. Now, how do we clean up the procedure all the way? Well, this is the trial that Hemel ran in South America. And the interesting thing to note is these are not high volume centers. No. These are centers that aren't doing many cases every day. And it's not like a lot of our centers where we're doing 200, 300, 400 cases a year. And yet, even with these centers that were only doing several cases a month, when they adopted the cusp overlap, their effective pacemaker rate was 5.7%. So again, this is something that can be learned and taught, and it's not just for the centers that have done 1,000. These are for centers that are interested in this valve and learning how to keep pacemaker rates well under 10%. But it was a very interesting study. Any comments, Kendra, Mohammed?
No, I think this just demonstrates that when you have a a scaled down technique that's easily reproducible, you can get outstanding results. Many of these sites did not have to go through the learning curve of transitioning from the pro technique to cusp overlap. They only learned cusp overlap, and so they didn't have bad habits to break, but the outcomes are excellent.
Yeah. And again, you
Yeah,
look at the numbers.
I agree. It's I was actually surprised to see the small numbers,
Yeah.
but the very large differences in pacemaker rate.
So commissure alignment and coronary access, you know, now that we have approval for low risk and we're going to see younger patients, I think the ability to line up our TAVR valves the same way that Kendra and I line up our surgical valves, commissure to commissure, is going to be really crucial, Mohammed, going forward. And so this is obviously what we want to see. We want to see the commissure to commissure so that the coronary is completely open. The worst possible alignment is getting a commissure right in front of the coronary. If I do that, it's going to make it very difficult for Mohammed or any of our interventionalists to get back in there. So this is a lot of work that's been done by Gilbert Tang, looking that if we put the flush port at 3 o'clock rather than the conventional technique where it's up at 12 o'clock, what that does, and what Gilbert showed is if we do this and get the hat marker on the outer curve, overall we can increase the number of times that we actually have an appropriate orientation of the valve. Now it doesn't get us to 100%, but it gets us up to about 2/3. And I think this is going to be crucial going forward. Let me turn it over to you for a minute, Mohammed, because you're our, I mean, even though Kendra is actually trained in interventional cardiologist, I hope she's not taking STEMI call anymore, but I suspect you still take STEMI call, Mohammed.
Yeah, I do.
What are your thoughts about this?
Yeah, it's extremely important. It's very important. And we can see this now in some recently published studies as well, like the Reaccess trial, that if you just implant the valve without considering aspects of reaccess, you will get into trouble as an interventional cardiologist, maybe in 1 out of 6 or 1 out of 7 patients. We learned, of course, as interventional cardiologists, a lot how to adapt our technique in order to be able to engage coronaries after TAVI, which is something that is a little bit different than engaging coronaries without a stent frame in there. But we also learned that maybe one of the most important aspects is to obtain commissure alignment. And in addition, I think commissure alignment will be also a very important aspect for valve function and also for redo procedures, which is something I think we are starting to see. We are starting to see patients coming with failing valves. And if the commissions are not aligned, we have less options to retreat.
And certainly as a surgeon, I've always thought the closer I could return things to the way they're supposed to be, the better people will do, whether I have data or not. Kendra, do you think it makes any difference as far as the function of the valve goes if you line up post to post?
You know, I've only seen some data. We work closely with Georgia Tech, and they have some computer-generated flow dynamic data. And I think that anything that lines up the sinuses more in their native orientation is helpful. But the biggest thing is reaccess, and then, of course, what's going to happen when you need a valve in valve.
Yeah. I think valve in valve and reaccess, and it really doesn't, I don't worry too much, Kendra, if you or Mohammed are going to see the patient, although if you get a post there, it's going to be hard for either one of you. What really worries me is my community cardiologists that are non-structural, non-TAVR cardiologists are very worried about this. And I think if we could tell them we could line these up like surgical valves in the community, there would be a lot less trepidation over this.
Certainly.
Yeah, I completely agree.
So I'm going to turn this over to you, Kendra, because this is your study.
Yeah, thank you. So I was interested in looking at the available data from all of the trials on self-expanding platforms that Medtronic has done. So this included over 5,600 patients in the TAVR side and over 1,800 patients in the surgical side across all risk levels. And basically what we were looking at is what was the mechanism for needing a reintervention and what were the outcomes. And here you can see that the reinterventions are uncommon across the board. You know, I would say out to 4 years, you're talking still interim analysis, but surgery 2%, core valve in this case, meaning the original core valve classic 0.8%. The purple line sneaking in there that it only goes out to about 2.5 years, that line is for the newer generation Evolut. So Evolut clearly has the least number of interventions, up to about 2.5 years. Important is that the TAVR interventions happened early, but the SAVR interventions continued over time. And this starts to give us some information about these patients. The deeper analysis also showed that most of the TAVR interventions were due to PVL, and they were treated percutaneously. And so, this to me is a signal that as we're looking at lifetime management, TAVR is a reasonable choice, at least out to what we see here. It'll be interesting as we go forward, and certainly the low-risk trials will give us a lot more information head-to-head, the self-expanding valves versus surgery. But this is what I wanted to know. I wanted to know, with the data we have available today, what can we say about what's the reintervention rate and what are the causes of reintervention?
And if we do have to reintervene, if we can't line up our commerce or post, and we just randomly put these in, the chances of Muhammad getting in later becomes diminishingly small.
But let me ask you, Michael and Kendra, something, because I mean, you're an interventionalist, you're a surgeon. The data we are seeing now for surgical explantation of TAVR devices are not that encouraging. But on the other hand, these are probably very biased data from old generation devices, high-risk patients with endocarditis maybe as the main cause of explantation, which is something different to explanting a TAVR device that has been implanted, for example, in the low-risk younger patient and has now degenerated, and we're thinking about doing surgery. Any insights on this?
I think that right now we have more questions than answers, but it's important that we're having the discussion. I think that most of the valves that are failing are in high risk and intermediate risk patients to begin with. We haven't yet seen the low risk patients fail. And so we don't necessarily understand what this is going to look like when this group of low risk patients needs a reintervention. But yes, as far as we know, the risk is higher for the second valve if you're removing a TAVR and then having to do some type of surgical intervention. And in this particular group of patients, in the data presented here, the risk of death after a surgery for removal of the TAVR valve was less than 5%. So in this particular group, across all risk profiles, out to 5 years, you saw very low risk, which is not consistent with what we're seeing in some of the other studies that are being published. But we'll know more. I do think that you're going to see a difference between removal of a self-expanding valve versus balloon expandable valve, but we need to study that. In terms of the TAVR valve failures and what to do next, and that commercial alignment certainly is going to play a role. Also, are we going to have a new issue, which is not valve to coronary, which we worry about in surgical valves, but valve to STJ or even valve to aorta, as the leaflet tissue is so tall. So I think that we will be coming up with answers to these questions over the next few years. But right now, we don't have that answer.
I tell you, the other thing that really worries me too, Kendra, is that the average heart surgeon in the U.S. does about 8 aortic valves a year. And although the volume is falling, it hasn't fallen that much, but it's likely to continue to fall. And in big centers where we're used to doing complex and root stuff, that's probably not an issue. But I do worry about the average heart surgeon out there, that if all of a sudden they're doing 4 aortic valves a year, will they handle these complex cases?
I couldn't agree more. I think we're actually creating a new entity, which is this, post-structural heart, open heart surgery, because you're going to see it in the mitral as well.
So listen, I'd like to thank everybody for joining us today for our discussion of some of our structural takeaways from TCT. I think it was another interesting year as we continue to fill in our knowledge gaps. I'm very thankful to my fellow panelists, Mohammed and Kendra, for your insight and the leadership that you both provide in the field. So thank you for joining us, and I hope you can join us for future presentations.